Hello, my name is Jason Grandeo, and I am a fellow in training with Evidence in Motion. Today I'm going to be discussing adverse neural dynamics, and more specifically, the evidence for the upper extremity examination. Objectives for this discussion will be to review the biomechanical and pathophysiological properties of nerves, review indications for using upper limb neurodynamic tests, describe normal sensory responses for each of the tests, to review the validity of the upper limb neurodynamic tests, and then describe positive findings that we will use for these tests. So the picture on the right, I think, is a great example of the concept of the nervous system being a continuum throughout the body. This is one of my favorite pictures, mainly because it was on display at my PT school, Hahnemann, which is now Drexel in Philadelphia. And this display is actually a dissection of a woman named Harriet, who was a cleaning woman at the school until her death in 1888. And Professor Rufus Benjamin took 5 months to dissect out the nervous system completely intact. And like I said, this is something that greeted us every day as we walked into the building where we had classes. And I would just always paused and just took a look at that, just looking at how unbelievable of a structure that is, and just I can't believe how challenging it must have been to dissect that fully intact. But it really is a great display of how the nervous system is a continuum throughout the whole body and is completely connected as it travels throughout the various structures. A couple other things that have helped us understand how stress is applied throughout the nervous system, throughout the tissue, through some cadaver studies. The first one there by Walsh, in which he showed that motion of the upper extremity causes stress along the entire course of the nervous system. And so it becomes really challenging because we might be applying movement at a distal portion of a limb or a proximal portion of a limb, and we might be stressing the nerve along the area that it courses at a point that is further away from where we're applying that movement. And that's just something we need to keep in mind as we're trying to perform a neurodynamic assessment. Kleinrensick et al. Showed that motion at the wrist increases strain at the cord level of the brachial plexus, and that contralateral lateral flexion of the cervical spine increases strain at the cords of the brachial plexus and the three major nerves in the arm. And so again, this just shows us the challenge that we have when we're doing a neurodynamic assessment, because we can't say, or I would say it's not likely that we're just stressing one nerve or any one particular nerve when we're applying these tests. And not only are we not stressing one nerve, but we are also stressing other types of non-neural tissue. And so it creates a situation where the neurodynamic examination can become challenging, and a lot of clinical reasoning needs to be applied in our testing when we're doing this, and also tying it back to the patient, their primary complaint, their primary symptom, trying to figure out if their issue is neural in nature or non-neural in nature, or a combination of the two. So before we get into the discussion on the examination of the upper extremity when it comes to neurodynamics, I think it's important to understand some of the mechanical properties of the nerves to better understand how neurodynamics may be impacted. And I'm not going to go through an exhaustive talk about this. I mean, you could spend hours discussing this, but I just want to hit some highlights to get us thinking along the lines of how the nerves and the nerves can be affected, and how the mechanosensitivity of the nerves can be impacted based on tension or compression as well. So the first point up there, tension within nerves affects intraneural blood flow and nerve function. And there was a study out there that showed that occluding a nerve's blood supply for as little as 2 minutes increases the irritability of the muscle it innervates. I think that's important to understand clinically, because again, we're trying to figure out is the individual's primary complaint a neural issue, a muscular issue, or a combination of the two. And I would say if it is neural in nature, they're going to present with multiple findings. So they might present with a muscle that's very guarded. They might present with a limb that has passive resistance to it because of that irritability of the muscle, or even the skin that nerve might innervate. And so keeping that in mind, I think, is really important as we go into the examination or the tests of neurodynamics. Tension is accommodated by both intraneural and extraneural anatomical designs, and we'll talk a little bit about that. Some of the intraneural characteristics, one that I found really interesting as I was doing some reading was these structures called spiral nerve bands of Fontana, and they're described by a historical review by Clark and Byrne. And the authors point out that if the brachial plexus of a rat is exposed, white bands in the form of spirals can be seen on the nerve trunks with the naked eye, and then use of a hand lens will also show them more clearly. They can also be seen in the peripheral nerves of many other animals, as well as in humans, and these structures help the nerve accommodate to tension. So I already see within the intraneural characteristics, there are structures that are designed to disperse tension or to respond when tension is applied. Also, intraneural gliding occurs between individual nerve fibers and their various coverings, those being the endoneurium, epineurium, and perineurium. When it comes to extraneural characteristics, the perineurium and the epineurium also contribute to that extraneural gliding by creating surfaces that allow for structures to freely move on one another. And as you can see in the chart here, proximal and distal excursion for the median and ulnar nerves have been recorded with movements of the shoulder, elbow, forearm, wrist, and fingers. So you can see here the amount of distance that nerve might be traversing, and here we're looking at the median nerve when motion occurs at the shoulder or at the elbow. And so again, it's those extraneural characteristics of the perineurium and epineurium that are allowing that gliding to occur. So let's turn our attention now to how pathology affects the peripheral nerves. And again, we're not going to spend a lot of time on this. I think it's just good to understand. I think if we're trying to do some patient education around what might be going on with a neurodynamic issue, it might be good to explain a little bit of this to patients so that they can get some buy-in as to what you're examining and then what treatment you might be applying to them. So if we look at the pathology or how that affects the peripheral nerves, basically we can describe three effects, and those are changes in neural mechanics, vascular perfusion, and then exoplasmic flow. And these factors contribute to the hyperirritability of not only the nerve, but again, of that tissue that they innervate. And so if we look at the vascular system, it could be of the nerve specifically, it could be compromised by external compression or adverse tension. And I think this is a good point to bring up this idea that we're getting away from using the term upper limb tension test or nerve tension issues, because now we're finding out that it's not only tension that could be impacting the system, but compression as well. At CSM this past year in 2015, or this year 2015, they really talked about in one of the courses I was in, getting away from using that term upper limb tension tests and using more of a term of upper limb neurodynamic tests. And as I go through this lecture, I hope that I use the term neurodynamics and not neural tension. If I do, please understand that I'm trying to change my language around with that. So again, the vascular system could be compromised by external compression or adverse tension. If this situation happens, there can be a release of chemical mediators and create a state of inflammation. And just like inflammation can irritate other tissues, it can increase the irritability of that nerve as well. These vascular changes could also alter neurovascular dynamics by creating a fibrotic situation within the nerve or around the nerve. And so now we've affected that nerve's ability to glide within itself, and then also in adjacent structures as well. And then finally, axoplasmic flow could be compromised by external compression. If we remember back to our learning about nerves and the physiology of nerves, basically what happens here is it affects the transport of the neural filaments, the microtubules, and the neurotransmitters along the axon to the terminal ending. And we remember that these chemicals flow along the axon down to the terminal ending, and then there's byproducts that are formed that then flow backwards back to that cell body. And when that axoplasmic flow is disrupted, it not only challenges the ability of these mediators to flow toward the nerve ending, but also for the byproducts to flow back to the nerve body, or the cell body, and thereby changing the ability of that nerve to function. L.V. Butler and Gifford describe the process of fibrosis as falling into two different categories. Pathophysiologic manifestations are symptoms reported by the patient, such as paresthesia or pain, whereas pathomechanic manifestations are alterations in the neural mechanics that limit isolated or multi-segmented motion of the upper extremity. And so we could have a manifestation where somebody's having symptoms that the patient is reporting, but also we could have a situation where we're seeing altered movement of a limb because of fibrosis around that nerve. And so that's why the neurodynamic tests really become an important part of our examination if it is something that's on our hypothesis list. L.V. and Butler also describe a resistance within passive motion due to altered neural mechanics. So Butler refers to these as tissue barriers encountered while performing neurodynamic tests. And if you've done these tests before, you might feel as you're moving the extremity, any part of the extremity, that limitation in tissue length. LV reports more of a protective reflex muscle contraction as contributing to that resistance within the passive motion test. And a lot of times I've felt that if I've got the shoulder depressed, let's say, and I'm extending the arm doing a median nerve test, you'll start to feel that that shoulder girdle begin to shrug up, trying to relieve some of the tension or the compression within that nerve. I don't know if we can say it's definitely one or the other. Probably, just like everything else, it's a combination of the two, the concepts of LV and Butler there. But definitely that's something that you're going to experience if somebody is, in fact, having a neurodynamic issue and you're putting them through these tests. So, again, not a lot there on the mechanics and the pathophysiological information, but I just wanted to put that out there to get us thinking about that as we move into the examination process. So as we shift our focus into the examination, let's keep in mind the neurodynamic testing techniques are multi-segmental, and we are applying stress to several different structures across a broad region. We are stressing tissues other than nerves, and I think that's something that we really need to keep in mind when we are performing these tests. And that's going to be a challenge in us trying to determine what structure is contributing to this individual's symptoms or this individual's functional issue. Keep in mind the continuous structure of the nervous system, thinking back to Harriet, and realize we need to understand what the normal response is to a neurodynamic test to help us better interpret a positive test. And so I think we've all experienced, as we've learned about these different tests, we've put ourselves in those positions, or we've had colleagues perform the test on us, and everybody gets some sort of symptom response. And the question always becomes, well, is that normal or is that abnormal? And so I think understanding how normal asymptomatic individuals respond to these tests will help us then determine what really is a positive test. Realize it is very difficult to isolate a particular segment of the nerve clinically. And then also we really need to understand that these tests can easily provoke symptoms. And caution needs to be taken when we're testing the moderate or the highly irritable patient. And this is something that the fellowship program has really helped me come to understand as I'm going through that subjective history exam with the patient, really understanding how irritable they are, how irritable their symptoms are, so that I can plan an objective examination that isn't going to irritate them early on in my exam and then confound the results of the rest of my exam. So these are tests that can be that really can ramp someone's symptoms up fast. So you really got to make that decision. Am I going to apply these tests early on in my exam or later on in my exam? So when we look at clinical application, I think the first question is, when should I perform these tests? And I think most of the time when we have someone that's presenting to us with neck and arm pain, and we have any suspicions of things like radiculopathy, the median nerve test is included in the test item cluster that Weiner created for determining if somebody does have radiculopathy. Epicondylalgia, and I think really when you've got an individual that has been diagnosed with epicondylalgia and is not responding to the typical treatment for that, or I think this is a diagnosis that gets thrown out there a lot when someone has lateral elbow pain and they come in and their report of symptoms seems more neural than muscular or musculotendinous. And so really getting a good understanding of what the nature of that individual's symptoms are can really help determine if we should be applying some of the neurodynamic tests to see if that is in fact creating the symptoms that they are experiencing. Repetitive stress injuries, if somebody has a history of that, I think that putting adverse neurodynamics on your hypothesis list, it needs to be on there. Carpal tunnel and cubital tunnel syndrome, and I'll talk a little bit about carpal tunnel in this discussion, and then I'll do another discussion on the treatment where we'll talk about carpal tunnel and cubital tunnel syndrome as well. Anytime someone's reporting neurological changes in the upper extremity, anytime there's a suspicion of peripheral neuropathic pain, and then again, really anytime that there's some where there's a recalcitrant neck, arm, or a combination of neck and arm complaints that have not responded to typical care. So if someone's coming in with a diagnosis that's non-neural in nature, and one that comes to my mind clinically that happened most recently is an individual that came in with a diagnosis of adhesive capsulitis. She certainly had some limited mobility in the glenohumeral joint, but if you looked at her active movement exam, the two pieces just didn't match up. There was some restricted mobility, but the amount of limited active movement that she had didn't marry up with the slight limitation in joint mobility that she had. And it really started to show how someone can be affected with an active movement exam when they have an adverse neurodynamic situation going on. And so, again, she had been doing treatment previously that was more typical of someone that had adhesive capsulitis and was not responding at all, and really had been stalled for a good 4 to 6 months. And so when you get that recalcitrant neck or upper extremity complaint and it hasn't been checked or cleared out, I think that's a time to perform these tests. So let's get into the neurodynamic assessment itself, and first we'll talk about the median nerve, also known as upper limb neurodynamic test 1. The median nerve bias, you see the steps of the test there. You place the patient in shoulder girdle depression, shoulder abduction, forearm supination, wrist and finger extension, lateral rotation of the shoulder, and then elbow extension. There is also upper limb neurodynamic test 2A, which is also a median nerve bias test. Sorry, let me step back 1 second to the neurodynamic test 1. This was first described by Elvey in 1979, and that date really jumped out to me because I don't know why, but I think that a lot of times we consider these tests as being something new, but in fact they are something that have been around for a long time and have been studied by a lot of wonderful individuals that have a great interest and a great amount of experience in working with this property. And so it is something that's been around for a long time. Upper limb neurodynamic test 2A also biases the median nerve, as I said before. And this test was developed later on as an alternative for patients that were unable to place their shoulder in the required position for the previous test. And so they're still going through shoulder girdle depression, but you can see the shoulder abduction is a lot less here. They're only in about 10 degrees of abduction. And again, it's when that shoulder or that glenohumeral joint or shoulder girdle is impacted so much that by taking them up, that they're not able to go higher in that abducted position. So the first study that we'll look at, again, it's based on looking at the median nerves, a study by Lowcamp and Small, where they investigated differences between gender, arm dominance, and structural differentiation in response to test 1 and 2A in normal subjects. And so structural differentiation is a way to help determine if the response to the test is caused by neural tissues or musculoskeletal tissues. And they make that remark, but I think it still can be challenging, even with structural differentiation, to say that we are just only testing the nerve. But as you'll see as we go through this, this is something that comes up time and again that helps us determine if the individual is having a neural type issue. So just something to keep in mind as we go forward. Study also investigated the sensory response in terms of frequency and nature of the response in different areas as they perform these two tests. So some demographic information there. 90 participants, they did not have any upper limb or neck injury within the last 3 months. Age range 18 to 49 years. They had 40 females and 50 males, and 77% regularly took part in different sports. Now, I think that may impact the generalizability of this study. I don't know in most typical orthopedic settings if 77% of our population is taking part in sports. So that certainly could impact a normal subject's response to these tests. You might think that in their dominant arm they might have better neural mobility, and so that could impact this study a little bit, and is just something to keep in mind as we move forward. So procedurally, both tests were carried out with and without structural differentiation on both arms. So they did the test with cervical movements and without cervical movements, and we'll talk a little bit more about that. The test order was determined randomly, and participants had a 10-minute break mid-testing to make sure they were not feeling a persistent response from a previous test. For reliability testing, each test was carried out 3 times with a 30-second rest in between. And then when they tested structural differentiation, basically what they did was they placed the head in a maximum contralateral lateral flexion position without causing discomfort in the neck or the arm, and then they applied the test in that position. So again, they did it without the structural differentiation, and then they again did it with the structural differentiation. So again, procedurally, they applied one test. Upon release of the test, they noted the location and nature of the sensory response, and they did that by having the subjects recorded on a body chart. If they had any difficulties reporting the sensation, they were prompted with the descriptors listed below there: stretch, pain, tingling, etc. And again, there's the comment about the structural differentiation. So implications and recommendations on their findings, just to talk a little bit about that, there was a wide range of normal values found in the study, which strengthens the reasoning behind the clinical practice of not solely evaluating these tests by comparing findings to normal values. So if we take that symptomatic patient, it's going to be very hard to apply what their findings are to what the normal is, because the normal values were so wide. And so what that tells us is that comparing side-to-side responses as well as symptom response needs to be considered, and would probably be more helpful in determining if the person has a neurodynamic issue or not. Gender did not influence the results of this study, and therefore findings indicating normative values obtained from mixed gender samples are valid, and they can be used for females and males equally. In this study, the highest frequency of response was felt in the anterior elbow, extending into the hand, as reported by previous studies. However, interestingly, they also had reports of sensation in the posterior arm and shoulder. And I think this goes back to that concept of the continuum. And this could be a result of the upper limb neural tension test 1, neurodynamic test 1, had to catch myself there, causing a mechanosensitivity response at the nerve root level versus the peripheral nerve level. Again, we cannot say what area we are stressing or compromising. So certainly symptoms or a response could occur in an area that we would not necessarily suspect because we cannot say for certain where we are applying a stress. Sensory response was reported more frequently with the upper limb neurodynamic test 2A as compared to 1. During test 1, other structures such as muscle could cause a response that is not neurogenic in nature. And again, that just goes back to that concept that we are stressing a lot of different tissues, including non-neural tissues when we perform the test, especially test 1 as compared to test 2A. With structural differentiation, frequency of responses significantly increased proximal to the elbow and decreased distal to the elbow. And I think we'll find out why when we talk a little bit about the treatment, and especially when it comes to median nerve in the next discussion. Most frequently reported nature was stretch, followed by pain. I think that's the important thing to note there is that the reason behind that is probably because these individuals were asymptomatic. And so they would probably feel a stretch before they would feel pain. So these results provide evidence for large individual differences in range of motion and sensory responses, which again highlight that need for bilateral comparison when we're performing these tests. Keep in mind there are differences in range of motion, frequency, and nature of sensory response between dominant and non-dominant arm, which can be normal and must be acknowledged when interpreting results of neurodynamic tests. Again, a more dominant arm probably has better neural mobility within it simply because we use it more frequently. So that is something to keep in mind when we are performing our bilateral tests. You might reach a limitation in movement on that non-dominant side faster than you reach it on the dominant side. And so understanding if we are recreating that patient's symptoms with that test really becomes important. So moving on to the radial nerve, you can see the test procedure there with the radial nerve bias, shoulder girdle depression, elbow extension, medial rotation of the entire limb, and then wrist, finger, and thumb flexion. We're going to look here at a study by Peterson et al. And the purpose of this study was to compare responses to radial bias neurodynamic testing between symptomatic subjects with a positive neurodynamic test, symptomatic subjects with a negative neurodynamic test, and asymptomatic subjects. And basically they tested 3 hypotheses. Subjects with a positive test would report sensation earlier during testing. Subjects with a positive test would report different sensations and locations of sensation on their involved side as compared with the other groups. And the subjects with a positive test would have significantly less passive range of motion measurements as compared to the other 2 groups. So here's a chart that gives the demographic information for each group. They had 36 symptomatic subjects with a positive radial nerve test, 24 symptomatic subjects with a negative neurodynamic test, and 60 asymptomatic subjects. In the chart below, you see subjects had to have symptoms either in the cervical region, the upper extremity region, or both. And as you can see, most people had symptoms in both. So the authors broke down the steps of the neurodynamic test to help determine at what stage of the test the individuals reported a sensation. Excuse me. And they also measured glenohumeral abduction, and when appropriate, cervical lateral flexion. So it wouldn't be appropriate if if the subject requested that they stop the test before they got to the cervical lateral flexion. So the protocol, they did use an external device to depress and stabilize the scapula, which could create some issues with generalizability. This might not be something that we have in the clinic. A lot of times we're just using our hand to block or to depress the scapula, and or we might be using another individual to help us out there. So just again, something to keep in mind. A list of sensations were placed above the testing plinth. Those were ache, burn, numbness, and you can read the rest of them. They're very similar to the last study that we talked about. Patients were instructed to use these or any other words representing sensations experienced, so they did not have to be limited to those descriptors. They were also asked to report location and sensation during each stage of the test. Glenohumeral abduction and contralateral flexion were measured, as I said before, and they used end field to determine the amount of motion at the appropriate joints, or they stopped motion based on request of the subject. So if they were going through, let's say, shoulder abduction, they would stop that when they either were instructed by the patient or when they met a typical end feel for that joint. So you can see here, this is a graph looking at the stage of first sensation reported. The blue are the individuals that are symptomatic and have a positive radial biased upper limb neurodynamic test. The red are the symptomatic negative radial bias test, and the green are the asymptomatic. And basically what you can see here is that this graph statistically supports the hypothesis that subjects with a positive radial nerve bias test would experience their first sensation earlier in the stages of testing. And so almost, not quite double the number of individuals here, but I think if you combine those first two stages together, you're going to see that the majority of the individuals that had a positive response here were those individuals that were symptomatic with the positive radial nerve test. I mean, that's helpful because symptomatic individuals without it, yes, they had a response here, but not to the same magnitude that the positive subjects did. As we see here, all groups reported the sensations that they had an option from across the whole board. Those were reported at one time or another. Stretch was the most commonly reported sensation. Here you can see that pain was reported as frequently as stretch in the positive radial nerve bias group, the symptomatic positive group. It was second most frequent in the symptomatic group with a negative test, and pain had the lowest frequency in the asymptomatic group. So because of this, pain may identify differences between individuals with radial nerve involvement and individuals with different nerve involvement or no neural involvement. So that could be something that we could use clinically if the individual is reporting pain versus stretch. That might be helpful in helping to rule in the possibility of a radial neurodynamic issue. Passive range of motion, the only significant differences noted for shoulder abduction. The positive radial bias group had range of motion measurements of 31 degrees, and the asymptomatic group had range of motion measurements of 37 degrees. There was no statistically significant difference for the symptomatic group with a negative radial nerve bias test. Passive range of motion differentiated only between asymptomatic positive radial nerve bias. So although it's helpful to know that glenohumeral abduction is reduced in the subjects with a positive radial nerve test versus the asymptomatic subjects, it does not help us clinically. So, I mean, clinically, we're going to be assessing people that are symptomatic, and we're trying to determine are their symptoms being driven from a radial nerve neurodynamic issue or something else. And so when we're assessing patients with neck or arm pain or both neck and arm pain, symptoms with radial biased neurodynamic testing, we cannot use a change in range of motion to help either confirm or deny the presence of some sort of radial nerve mechanosensitivity. And so that is something that we have to put aside as using that's going to denote either a positive or a negative test for us. There was no statistically significant difference reported in sensation across the 8 locations between any of the populations. And so this finding helps us understand that we are not only stressing a specific nerve with neurodynamic testing, and we understand that other structures are being influenced, which may result in a response from a symptomatic and asymptomatic individual. We can't necessarily use location of sensation as a factor to rule in or rule out the presence of radial nerve neurodynamic issue. So based on these findings, symptomatic subjects in both groups reported similar findings during testing, which creates a challenge clinically when attempting to determine the involvement of the radial nerve. And so things to keep in mind from this study is, again, they use that external device, which may not be realistic clinically. Symptomatic subjects with a positive or negative radial biased nerve test reported similar findings during testing. So again, that just creates a challenge for us in trying to rule in or rule out neurodynamics as an issue. The area of sensation response cannot be used to determine if a test is positive or negative. So then what do we do? So I think radial nerve mechanosensitivity suspicion increases if, and again, this is based on the results of this study, patients presenting symptoms occur during the first stage of the neurodynamic test. Again, we look back to the results. The patients with a positive radial nerve test had symptoms occurring early on in the test. If pain is the reported sensation with testing, especially even more so than stretch, the stretch was reported by all 3 groups, but pain was reported more frequently by those individuals with a positive radial nerve test. And if reproduction of the patient's symptoms is influenced with contralateral cervical lateral flexion or ipsilateral cervical lateral flexion. So, and I think that we need to consider not, ipsilateral lateral flexion could be compressing that nerve or relieving tension on that nerve. And so I don't know if we can necessarily say that the contralateral lateral flexion is going to increase their symptoms and the ipsilateral is going to decrease it. I think the key conclusion there is that it influences the individual symptoms. Okay, so moving on to our final nerve. We have 2 more studies that we'll look at, but this is the final one that looks at just one single nerve. So we're going to talk about ulnar nerve bias test. This is upper limb tension test 3. There you can see the positions that we're going to put the upper extremity in to perform this test. And we're going to use a study by Martinez et al. And the objective of this study was to describe the normal sensory responses to the ulnar upper limb neurodynamic test and investigate the influence of sex and arm dominance. And so you can see the flow chart of the study here. They had 57 subjects between 18 and 50 years of age with no previous or current symptoms in the cervical region or the upper limbs. The procedure that they used is here. The patients were supine without a pillow. They applied the test twice on each limb with a 30-second rest between. Again, similar to the way I had described it earlier. Patients were instructed to report symptom onset, indicate point of pain tolerance. They were to rate their pain 0 to 10. They recorded the shoulder abduction angle and also reported the quality and distribution of symptoms with similar descriptors as the other studies. Findings there was a statistically significant main effect difference in hand dominance and shoulder abduction angle. And so the shoulder abduction angle was higher in the non-dominant arm. There was a significant sex main effect difference in pain intensity and shoulder abduction angle. Pain intensity was higher in women, and shoulder abduction angle was higher in men. The sensory response was principally located in the medial forearm along an ulnar nerve distribution. And the nature of the response in the dominant arm, 91% of the time was stretch. The non-dominant arm, 89.5%. And pain was the second highest in nature at 57.9% in both dominant and non-dominant. The percentages here are high because each participant could report more than one sensation. So, implications and recommendations for this study. Even though shoulder abduction angle was found reliable between the dominant and non-dominant arm, it may not be clinically significant. If you look at the degree difference, it was only 6 degrees, so that really falls into a possibility of a measurement error. And so, again, it was relevant or significant, I should say, in the lab, but that might not be significant in the clinic. So just, again, something to keep in mind there. Again, we're seeing that trying to find a normal value for these range of motions when we're doing these tests is really not showing up as helpful for us. However, the difference in pain, women demonstrated more pain, less shoulder abduction, and this has not been consistent with previous studies, but if you look at the difference in the pain report, it was less than 2 points. And again, so this may not be clinically significant. So it's not meeting the MCID for an MPRS for pain. So again, it was significant in the study, but it might not be significant for us in the clinic. The 2 most common sensations reported were not neural in nature. So this study was completed on asymptomatic individuals, which may be a reason behind this. But again, we must understand that this test, like the other neurodynamic test, stresses all the tissues in the upper quarter. So we certainly might get a sensation report that is not neural in nature. And so because of this, as with the other neurodynamic tests, we must use symptom reproduction and modification with structural differentiation to help us interpret a positive test. We're not seeing these. We're seeing these normal findings as being so broad across these subjects that we can't really narrow down what normative findings are and then compare that to the non-normal finding. So we have to keep falling back to the idea that symptom reproduction and structural differentiation are going to be the things that help us rule in or rule out the presence of a neurodynamic issue. So finally, a clinical commentary by Ni et al. Looked at the validity of upper limb neurodynamic tests for detecting peripheral neuropathic pain. They did a structured search for peer-reviewed articles published in English before May of 2011, and they found that biomechanical and experimental pain data support the plausibility of upper limb neurodynamic tests, which is good. So it's saying that we are likely testing what we're trying to test here. It is plausible that we are placing the neural tissue in a position that is stressing it in a way that we are trying to test. And I think the conclusions from this search really give us a nice conclusion to the evidence review here. And so just things to keep in mind, not only based on this clinical commentary, but also the other 3 studies that we talked about. Positive upper limb neurodynamic tests should at least partially reproduce a patient's symptoms. Structural differentiation should change the symptoms, and the clinical use in this manner is reliable. So that is a good thing for us. There's limited evidence suggesting that the median nerve test helps determine cervical radiculopathy, and again, that's probably why it's used in that test item cluster that Weiner developed. Radial nerve testing does not, though. So if we are trying to rule in, rule out cervical radiculopathy, median nerve testing can help us, but radial nerve testing does not. Interestingly, median nerve testing does not help in making a diagnosis of or ruling out carpal tunnel syndrome. I think I talked before about lateral epicondylgia being a diagnosis that people come in with a lot just simply because they have lateral elbow pain. I think carpal tunnel syndrome is another diagnosis where people come in with a lot just because they have a sensation change in the forearm and hand. But we can use that median nerve test to help us figure out if there is a neurodynamic issue within the median nerve, but we can't use it to help us determine the presence of carpal tunnel syndrome. And there is a test item cluster for carpal tunnel syndrome that we can use. Only evidence assessing concurrent validity of ulnar nerve test is a case study on cubital tunnel syndrome, so there hasn't been a lot of work done on the ulnar nerve out there, and I will talk about the case study in the evidence review that I do for treatment. So I hope this was a helpful discussion today. I hope it helps you think about when you're applying these neurodynamic tests, what we can reliably use as positive findings, and hopefully it'll help you streamline your testing a little bit more, understanding that measuring ranges of motion and those sorts of things aren't really going to help us determine if there's a neurodynamic issue going on. And there's a list of references. So thank you very much.